Thank you for your patience. So the presentation that I'm going to make right here, I've entitled Liver Tumors, the Fundamentals of Interpretation with CEUS. And so obviously I've been doing this for a long, long time. And a few years back, it struck me that although there's lots of rules and lots of exceptions and lots of important little things you need to know, that in actual fact, there's some fundamental things that are so important, and that if we know those, that really helps us to keep going. And so I don't have any relevant disclosures, but I will make a comment that some of the schematics that I include are part of a publication that my STAR student, David Burrows, made that was in radiographics a couple of years back. And it's really a great thing that I know that when my students go to the equivalent of AFIP now, they say that teacher says, this is the best publication you can read on how to interpret a liver mass. So I refer it to you. So Radiographics 2017. Now, contrast enhanced ultrasound is the approval indication for CEUS worldwide. And so it includes obviously liver mass characterization, which answers the question, what is it? And liver mass detection, or answers the question, is it there? So the algorithms that we have for diagnosis of these masses are similar to those for the non-invasive diagnosis of liver masses on CT and MR scan. And these are based on enhancement characteristics in the arterial and the portal venous phase. And we have to recognize that CEUS additionally has the unique advantage of superior temporal resolution and also exquisite vessel morphology. So in this presentation, I'm going to highlight the fundamental principles for interpretation of liver masses on CEUS. And this is with two basic objectives. The first one is to determine if the mass is malignant, and the second one is to establish a specific diagnosis. So I call these ultrasound pearls. So pearl number one, based on the conversation that we had earlier, is that which determines whether the mass is malignant or not. So even though we've already done the arterial phase, we're looking on the observation of the lesional enhancement in the portal venous and the late phase relative to the liver. And we recognize that washout has a very strong association with malignant outcome. This is not an absolute rule, but there is a strong association. So if we take time zero and we look at a patient on a CT scan with contrast and on CEUS, you can see a very concordant result in that both of them show a hyperenhancing mass with a central scar. And if we continue to watch over time, you can see that we show washout in both, again with our non-enhancing scar. So what do we think? Well, on both, the interpretation is the same, and these are malignant tumors. Now, pearl number two obviously is the corollary of that statement, and that is that benign tumors generally show sustained enhancement in the portal venous and late phase. So if we look at one of the most typical examples, here we have a young asymptomatic woman with a hypervascular exophytic mass in the liver at the peak of arterial enhancement. And if we watch this mass over time, you can see that on the CT scan, the mass remains iso-enhancing relative to the liver, whereas on the CEUS for 4 or even 5 minutes, the mass continues to show sustained enhancement and in fact remains in excess of the enhancement of the adjacent parenchyma. So this, of course, is benign, and this is a classic FNH on both CT and on the ultrasound scan. So now pearl number three is a very important pearl. So that says that benign tumors are characterized by specific vascular and filling patterns in the arterial phase. And these are optimally shown on real-time dynamic CEUS and in preference to CT and MR scan. So let's look at the little algorithm that we made years ago. You can see that's from our publication from 2006. So if we consider that overwhelmingly the benign tumors that we see are hemangioma, FNH, and adenoma, that gray box represents what happens to them in the arterial phase. So you can see that there's little pictures that show what happens to them. So the hemangioma has those little peripheral puddles on the edge. FNH has that central filling and the star-like appearance, and an adenoma can be dysmorphic, but if it shows vessels, they tend to come from the periphery to the center. And so it's that appearance that they have in the arterial phase that allows us to be suspicious of them right when we're watching that wash-in clip. Now, if we look over to the right, you can see all those white ovals. Well, that's what happens to them in the portal venous phase. And you can see that although the hemangioma may only partially show sustained enhancement, that they're pretty good. They stay sustained enhancement. And of course, the adenoma, if you remember something from this talk, you want to remember that adenoma is the exception to all the rules. So we'll show that as we go along. So let's talk about hemangioma first. So overwhelmingly the most common tumor shows peripheral nodular enhancement, centripetal progression of this enhancement in either the arterial or the portal venous phase. So let's look at a hemangioma. So there we can see that we have our tumor with its peripheral puddles that proceed centrally. And when we see on our schematic, what does that schematic show? It shows that these peripheral puddles are exactly that. They're puddles. They do not represent linear vessels because they represent vascular pools of blood rather than linear vascularity. So the distinction of peripheral puddles from linear vascularity is a very important, very underemphasized point, but it's something that I personally think is very important. So let's look at this patient and show something else that's very important. So this is a patient that's at risk for HCC. So on her surveillance scan, she shows a nodule, a hypoechoic nodule with an echogenic rim. So it's above 1 centimeter. She's at risk, so we do CEUS. So when we do the CEUS, you can see that she's breathing, but you can see quite easily that this tiny nodule has got very small peripheral puddles that very rapidly fill in to the center of the tumor, making it uniformly enhanced. So we back up in that clip and we take these pictures that allow us to see the peripheral puddles and their centripetal progression so that the nodule is completely enhanced by 35 seconds. And then at 1 minute, we show that it's still enhanced, and at 4 minutes, it's still enhanced, and at 6 minutes, it's still enhanced. So what is this? This is a flash-filling hemangioma, and on ultrasound, we can say that this is a benign lesion, and it needs no further investigation. Now, a subsequent MR was performed, not temporally related, but we can see on the MR scan that on the T1 vibe and on the T2 image, we can see this nodule, and it's bright on T2, not very bright, but bright. And then when we do the gadolinium images, though, we can see that the nodule, in fact, does not show those peripheral puddles and does not show that centripetal progression. And so only ultrasound can see that progression in rapidly or flash-filling lesions. And so this, of course, is a big advantage for ultrasound. So what about focal nodular hyperplasia? A very common nodule, stellate vascularity, centrifugal filling, and sustained enhancement, often with an unenhanced scar. And so when we look at our little schematic, we can see that when we inject the contrast, that we see with linear vessels filling from the center to the periphery of the mass. And when we look at our contrast exam, because it's filling from the center to the periphery, we have the appreciation that the nodule looks larger because of the fact that it's filling from its center to the periphery. And when we look at 1 minute and 3 minutes, we can show that there is sustained enhancement, and we do not ever show washout. Now, adenoma, as I've mentioned to you, is the exception to the rule. So first of all, adenoma is a very rare tumor in comparison to the frequency with which we see both hemangioma and FNH. So the fact that it's an exception to the rule does not cause us so much of a problem. But adenoma also is a very much more important mass, and it's important for 2 reasons. First, a risk of malignancy, and secondly, risk of malignant transformation. And so what do we see? Hypervascularity, although not the same as FNH. And the filling is diffuse or chaotic, and if we do see the filling, it tends to be centripetal, so from the periphery of the mass to the center. And then another big exception is that the portal venous phase is variable. And in our own experience, one half of all the adenomas that we see show washout, and the other half shows sustained enhancement. So let's look at this patient who has got an adenoma filling from the periphery to the center. And so we can see that very nicely on our schematic and on our AVI. And then when we watch at 3 minutes, we can see that there's partial weak washout. And so this was a patient who did not have good demographics for us to say that that was adenoma with confidence. So whenever we see that washout, because there's a risk that that could be a malignant tumor, we always do biopsy. And so the thing that we pick up is not hemangiomas and FNHs, but we pick up adenomas. But they're important to diagnose anyways. We need to have confidence that that is what we're looking at. And so, of course, with lesions like this, once they reach 5 centimeters in size, for example, it will be removed surgically in any case. Now, so pearl number 2 is that benign tumors generally show this sustained enhancement in the portal venous sacs. And what's the exception to that? The exception is hepatic adenomas, and they are benign, but they show late and weak washout. So let's look at another patient, a 25-year-old female with a very fatty liver and right upper quadrant pain. So that mass is a big and black mass, and it's in a big and white liver. So the liver looks concerning, the mass looks concerning. So we're worried about this anyways. So when we inject the contrast, you can see this is not a hemangioma. This is not an FNH. And so it's got a rather disorganized kind of enhancement. And so that could be an adenoma. Now, could it be something else like an HCC? Yes, but in a 25-year-old female, not quite so likely. So when we look at this further, there's our 11 seconds, our 44 seconds, hyper-enhanced, heterogeneous, and then definitely this is washing out. So this is going to come to biopsy. This is biopsy. This is hepatic adenoma, and this is surgically removed. Very, very good decision because of its size and its diagnosis. So when we look at these little clips before we leave these lesions, you can see that the top right image, which is being imaged with bubble tracking technique, shows us those beautiful stellate vessels with centrifugal filling. The hemangioma shows us the discontinuous globules with centripetal progression and no linear vessels. And the adenoma on the left shows us filling from the periphery into the center with a vascular pattern. So when we do the arterial phase injection on a benign tumor, right when we are injecting, we're thinking as we're watching that wash in, gee, this is a hemangioma, an FNH, or possibly an adenoma. And this is not true for the malignant tumors where the arterial phase does not help nearly as much. So malignant tumors are not diagnosed by their arterial phase pattern of enhancement. The biggest indicator of malignancy instead is if they have washout. So the patient on the top has got an FNH with arterial phase hyperenhancement and no washout, whereas the patient on the bottom is a patient who came to our emergency department with abdominal pain, abdominal mass shown on his ultrasound scan, and with contrast we can see it hyperenhances and it washes out. We say that's malignant and we do biopsy. So very, very efficient management of masses on ultrasound. So pearl number 5 is we're just talking about washout now. So both the timing and the intensity of washout have been found to be discriminatory between hepatocellular carcinoma and non-hepatocellular malignancies. And by saying non-hepatocellular malignancies, we mean all of them. So everything that's not HCC that is malignant is a non-hepatocellular malignancy. So pearl number 6, hepatocellular carcinoma shows arterial phase hyperenhancement, and it shows washout that tends to be both late, so that is greater than 1 minute after the injection, and weak, and that is to have retention of some bubbles between the washout area. So let's look at a beautiful scan. So here's a patient with hepatitis B virus, and he has that nice nodule in his liver. You can see again that he's breathing when we're doing our injection, but it doesn't matter. We can very easily show that this is a hyperenhancing mass corresponding with the grayscale abnormality. So we go back in our clip and we take the image at the peak of the arterial phase. We take an image at 1 minute, definitely the mass is showing sustained enhancement at 1 minute. And then at 2 minutes, we can see that the mass is about virtually isovascular with the liver. And at 3 minutes, there's weak washout. So this is a classic hepatocellular carcinoma, APHE, and late and weak washout. And so pearl number 7 is that metastases tend to wash out very fast. And this is often within the time frame that's actually defined as the arterial phase. And when they wash out, they tend to wash out completely. So when we're looking at these malignant liver tumors, you can see in our column for the metastases in that gray bar, which we determined was what happens in the arterial phase, you can see when you're injecting the contrast, you might see rim enhancement, you might see diffuse hyperenhancement, or you might see hypoenhancement. And when you see those things, you don't know what to think because they're not typical. They're not those specific patterns that we know suggest benign disease. However, what distinguishes the metastatic disease is that regardless of what happens in the arterial phase, when we come to the portal phase, it's going to be a black hole. And so that's the discriminatory feature for metastatic disease. And so let's look at 3 patients that all have metastases, and they're looking at them with CEUS. So we can see, as on the schematic, a rim, a diffuse hyperenhancement, and diffuse hypoenhancement. And these are metastases demonstrated by their behavior in the portal phase. So here's a 58-year-old man with colorectal cancer 2 years ago. And when we look at him on the baseline, we see a small nodule in his liver. At 18 seconds, it's hyperenhancing, and at 1 minute, it's completely black. And when we look at that little movie, which is not the most exemplary movie, but you can see this moving lesion is hyperenhancing, and then suddenly it has a black center. And that's how we see those lesions, very importantly, as Mets. And we looked at this one before, so I won't show that to you again. Now, pearl number 8, contrast-enhanced ultrasound in the portal venous phase improves detection of metastases over baseline. And this is related to their increased conspicuity. And this allows us to see both more and smaller lesions than we see on baseline scan. And so, of course, with pearl 8 is the fact that sweeping of the liver is the optimal time and technique for detection of liver metastases. So in patients at risk for metastases, we always do portal venous phase sweeping of the liver. So this is the most shocking and wonderful example I've ever had. It's an old scan, and I'll make the point that it's a very old scan because I've never had another example that was quite this striking, but I share it with you anyways. So this is a patient who came to our emergency department when I was still in Toronto, and he ended up with an abdominal ultrasound. And so one of my colleagues called this liver normal. And I re-looked at the pictures and I thought, you know, give or take a few little comments here or there, looks pretty normal to me too. So the patient ended up in the OR, and a very astute anesthetist called me and said, Stephanie, can you bring those bubbles and your machine to the OR? He said, I don't think I should put this patient to sleep. His liver feels like a rock. So I go up there with my bubbles and the machine and we inject them. And you can see that that virtually normal looking liver is filled with occult metastatic lesions. And we see them beautifully with CEUS. Now, pearl number 9, other non-hepatocellular malignancy is often showing rim enhancement, but the most important thing that it shows is rapid and marked washout. And so this is similar to metastatic disease. So you have to remember that if you have multiple metastases, they're very easy. However, if you have a solitary metastasis, it's often not distinguishable on many imaging techniques from other non-hepatocellular malignancies. So they behave the same. So let's look at this beautiful case. So this was a 66-year-old male, not with risk factors for HCC. So he had a mass on an outside ultrasound, and he was sent to me for characterization of this mass. So when we look at that little clip, let's wait till it starts over, which is now. So immediately we inject the bubbles. We know it has APHE, right? So we're still watching in the same clip, which is only about 20 seconds long. And before your eyes, it's already starting to go black. And then right before our eyes, in that same clip, it really is black. So at 12 seconds, hyper-enhanced, at 23 seconds, weak washout, but 2 minutes 30 seconds, marked washout. So what do we say? Definitely malignant. Very, very suggestive that it's non-hepatocellular, and they should do a biopsy. So the biopsy's done, and so this is not a risk patient, but this is cholangiocarcinoma. Now, pearl number 10, intravascular microbubble contrast agents show accurate washout as a reflection of malignancy, whereas CT and MR scan using interstitial contrast agents may show instead pseudo-enhancement. And so way back at the time when Peter and I were working together doing all those cases, we realized this discordance between CEUS and CT and MR scan. And this was the case that really started us off. So this is a 27-year-old male who comes with abnormal liver function tests. He had a surveillance scan looking for an explanation, and it showed a focal mass in the liver. So at that time, we didn't have our popularity that we now experience. So the patient went first for a CT scan. So you can see that they confirm the mass that was shown on the ultrasound. And so it shows a heterogeneous enhancing mass in the arterial phase. And then in the portal venous phase, it shows increasing enhancement, increasing intensity, and increasing amount of enhancement. And so that's an indeterminate result. I've shown this to many people, and lots of people think, gee, maybe that's a hemangioma. I don't know what that is. So then the patient went from CT to the MR scan. And you can see that the MR scan shows exactly the same thing, a heterogeneous enhancing mass in the arterial phase, and then increasing intensity and amount of enhancement in the portal venous phase. So this was still kind of indeterminate. Keep in mind, this is a 27-year-old man. So the patient was referred to the new kid on the block, and that was us at that time. So that was CEUS. So in the arterial phase, we agree with CT and MR. It's a heterogeneous, hyper-enhancing mass. But then, bang, before our eyes, it went black. So I just said, I don't know what it is, but it's cancer. And so we should do a biopsy, which they did. And so what is this? In a 27-year-old, this is a cholangiohepatoma in a normal liver. And so that's a very, very astonishing thing. And over time, I've come to realize the benefit of doing ultrasound for indeterminate CT and MR of this nature. So this portal venous phase discordance, why does it happen? Ultrasound shows rapid, brisk washout, and CT and MR show instead either sustained or increasing enhancement. Well, CT and MR contrast agent passes into the tumor interstitium, and this happens especially in patients that have non-hepatocellular malignancy, because those are the tumors that have the most permeable endothelium. So this little schematic was made for me by one of my students a long time ago. And so you can see that the enhancement intensity on CT and MR relates to the vascular volume, but particularly to the vessel permeability. Now, when we come to the microbubble contrast agents, instead, the enhancement intensity is only related to the vascular volume, because the bubbles cannot get out of or get through the vascular endothelium. So the ultrasound pearls that we talked about are washout as the most important indicator of malignancy. And of course, the corollary that sustained enhancement generally suggests a benign outcome. That benign tumors are characterized by specific and very suggestive arterial phase enhancement patterns. And although we must do the portal venous phase, we're suspicious of their presence as soon as we're doing those arterial phase wash-in clips. And that malignant tumors are not characterized by their arterial phase enhancement, but by the presence of washout. And washout timing and intensity discriminates non-hepatocellular malignancy from HCC, in that HCC is characterized by late and weak washout, whereas non-hepatocellular malignancy is characterized by rapid and marked washout. And of course, the intravascular microbubble contrast agents will show washout when interstitial contrast agents for CT and MR scan may show instead increasing pseudo-enhancement. And so that's my summation of what I think. If you know all that, You'll do pretty well. Thank you very much. Is there any questions just while I'm changing computers with Richard here? Clear. I stepped on the plug.
You're okay.
Yes? Sorry? How frequently will FNH so stellate vessels? So virtually all, but not all. So virtually always we can see it. And of course, it depends on the quality of your scan and how well you can get the lesion into your field of view. And so virtually all of them do. But some of them can be more difficult, of course. So there's no question that I do recommend some Primavist, or you call it EOVist, MR scans, but they're the infrequent scans for sure. It's a very, very good.
Any of them demonstrate a washout?
Oh, yes. So occasionally, so in our own study that we did a long, long time ago, we thought maybe as many as 10% can show some washout. But so here is kind of a philosophy that I have that's maybe not the safest thing to say, but I end up saying it to my students so often I realize that this is something that's an issue. So when I'm thinking that a patient has FNH or hemangioma, I had said already that I think that right when I'm doing the scan, like in other words, I'm doing the injection, I'm thinking this is FNH or I'm thinking this is hemangioma. With hemangioma, if I'm really sure that that's what I think it is, if it subsequently shows some washout, I just say, I don't care. I'm not going there. I'd say hemangioma. Now, FNH you have to be more careful about because over all my years that I've been doing this, I now have got about 3 histologically proven HCCs that have stellate vessels. So it's nothing is a slam dunk. It's great, but it's not a slam dunk. Okay, so now Richard's going to do the same thing. The fundamentals of interpretation of renal masses. And before Richard starts, I will say that when I met Richard works in an oasis of urology. And so it's a most amazing thing that even though liver is the approval indication, there's no question that if you work in an environment where you can start drawing on your urologist to send you patients, urologists and nephrologists, anybody that takes out kidney masses or manages kidney masses, once they find out how incredibly good ultrasound is for kidney masses, they will never do without it.